Dr. KRIPA. She's a second year family medicine PG from Bangalore Baptist Hospital. And it's my privilege to introduce Dr. Chetan, consultant pediatrician, director pediatric super specialty services from Manipal Hospital. Welcome, sir.
Hi, welcome.
And
Good evening to all.
Thank you, sir, for coming. And I also would like to welcome Dr. Srividya, Head of Department of Family Medicine, Bangalore Baptist Hospital. Welcome, ma'am.
Thank you, Disha.
We'll be starting the session.
May I start? Hello.
Yeah, we can hear
Yeah,
you,
please
Dr.
start.
KRIPA.
Yeah.
So good evening, sir. Good evening, everyone. So I'm here to present a pediatric case of a child. His name is Mohammed Zahan, who is a 10-month-old male. The informant was the mother. Information is reliable. The date of admission of the child was on the 20th of January this year, and the date of examination was one day later on the 21st of January. So the presenting complaints were fever since the past 6 days, cough and cold for the past 4 days, loose stools for the past 4 days, and rashes for the past one day. History of presenting illness. The 10-month-old baby boy is apparently well until 6 days back when he developed fever. Sir, is it echoing?
It is a little bit echoing and voice is breaking in between. So you can try again, no problem. I think you continue, it is okay. But if you are opened in two systems, I think close one system if possible. That's all. Or a phone or something like that if you are open in two systems.
So I haven't opened my phone.
Sure, I think that's fine, no problem. If nothing much can be done, we can proceed.
Okay. So this 10-month-old baby boy was apparently well until 6 days back when he developed fever, which was insidious in onset, intermittent in nature, low grade to begin with, subsiding partially with oral antipyretics, but recurring soon after. And the baby was active during the interfebrile period. And this fever progressively increased in grade over the next 4 days. Documented temperatures were in between 102 to 103 degree Fahrenheit, at the end of which he was administered antibiotic syrup from the same clinic wherein he was given the oral antibiotics initially, after which it would subside temporarily. However, the baby would continue to spike fever soon after. 2 days after the onset of fever, the baby developed cough and cold, which was cough was dry in nature, with no diurnal or postural variations. No history of fast or noisy breathing was noted, and the cold was more of rhinitis. The child was also noted to have mild watering from both the eyes. And since the past 4 days of presentation, the baby had loose stools as well, which were multiple episodes per day, watery inconsistency with no history of blood or pus in stools noted. The baby had a history of reduced food intake because it was mostly
Start from the previous slide again. You may have been open in two devices because it's showing. So it's KR, it's open in two devices actually. That is why it is echoing. If not, then it's fine, no problem. You can proceed from the history of presenting illness. Or the slide before that, sorry, slide 7.
Okay.
Slide 7, put it in slideshow and then you can restart again.
So the child had reduced food intake, which was more because the child was refusing to feed. And on the night of day 6 of illness, the baby developed rashes, which started from behind the ears, spread to the face, neck, chest, but spared the upper and lower limbs. They were reddish in color, and the fever persisted with the appearance of rashes. And there was no history of reduced urine output, crying while passing urine, or discolored urine. No history of ear discharge. No history of long distance travel. There were no history of seizures or altered sensorium. There was no history of exposure to pets, no history of bleeding manifestations. Treatment history. On the fourth day of illness, along with symptomatic management, the baby was given 1 dose of oral antibiotic from the nearby clinic. Past history. There was no history of similar episodes in the past, no history of prior hospitalizations. Birth history. Antenatally, the mother had gestational hypertension. Natal history, the baby was late preterm, normal vaginal delivery, and birth weight was 2.4 kilograms. The baby cried immediately after birth. Postnatal history, the baby had a stay of 3 days in NICU in view of respiratory distress. Development. Development was appropriate for age. Gross motor milestones, the baby would stand with support, read, sit without support. Fine motor, had a mature pincer grasp. Language, the baby would utter bisyllables, 2-lettered words. And social, the baby would bye-bye, peekaboo, say tata. And immunization, he was immunized up to 14 weeks of age as per national immunization schedule. BCG scar was present. He was not administer the MR vaccine at 9 months of age because he was suffering from upper respiratory tract infection at that time. Family history is an only born child to a non-consanguineously married couple. Mother had cough and cold 8 days back. Diet history. The baby was on formula feed from 2 months of age, thrice a day. He was weaned off at 6 months and complementary feeds were started at 6 months of age. He takes both vegetarian and non-vegetarian diet. And diet chart was made as per the 24-hour recall method. As per the diet history, his energy intake per day was 712 kilocalories, whereas the requirement was 1060. So the deficit was 348 kilocalories. Protein intake per day was 17.3. The requirement was 11. So there was an excess of 6.3 grams per day. And this diet, 67% energy requirement was met with this diet of the child. And according to the socioeconomic status was evaluated as per modified Kupaswami scale, and the family belonged to upper middle class. So shall I go into the summary of the history?
Yeah, summary of the history will be fine. Before you start examination, then let's take a pause and then we can discuss. So summary, you summarize and then we'll see. Yeah.
So here is the case presentation of a 10-month-old baby boy, only born child to non-consanguineous parents as a preterm, immunized up to 15 weeks of age, with appropriate development for age, with no significant past history, presented with a history of fever of 6 days duration, followed by cough and cold, loose stools, reduced oral intake, and the appearance of generalized reddish dryness. The above history is suggestive of fever with rash, likely of infectious etiology, probably viral.
Sure. So thank you for, I think, the history so far. So keep the slide on in terms of the presentation for now. So it's a 10-month-old baby who has come to us with fever and rash, and the temporal relationship between the onset of symptomatology is a fever, cough, coryza, and then appearance of generalized rashes, and the fever continuing at the height of at the onset of rash as well, isn't it? So the deduction in terms of that it is of an infectious etiology, probably viral. Any other kind of differential diagnosis would you like to consider, and what are your kind of supporting statements in the history which suggest that it is of an infective etiology, and what infective etiology are you exactly thinking about?
So the reason that it could be infectious etiology, probably viral, is because it is a multi-system involvement, and there was a contact history. That is, the mother in the family had a cough and cold around 8 days back, and during the interfebrile period, the child was active. So in bacterial infections, what we mostly see is that the child will be from the onset of fever. The fever would be of high grade, and the child would mostly go into a toxic state, much more sick looking than how it would be viral. And it would mostly be a single focus. Whereas here, it was mostly upper respiratory tract infection symptoms that was predominant in the child. There was no uh, features of LRTI, which is why, and viral exanthems are more common in this age group, which is why I thought it could be viral.
Sure. So the points that you brought out, one is that the difference between the pattern of fever for a bacterial and viral infection. So in the initial phases of bacteremia, you may still get a fever without apparent focus, which will become apparent within as the disease evolves. But the point that interfebrile period child is well is points more towards a viral infection. Okay? Again, in terms of a contact history, in this case, the mother herself, who is in close proximity to the child, again suggests a viral etiology, more common, but it cannot rule out other bacterial causes of infection, especially in the acute tonsillopharyngitis and upper respiratory bacterial infections can also manifest. But again, as the disease progresses, child will become slightly sicker and sicker. Okay, and the interfebrile periods will be accompanied with the child looking more toxic, more tired, and then the localization of infection also can start happening. All right, so those 2 points were brought out nicely. So if you're thinking about possible infective etiology, which is viral, which virus are you thinking about in this particular child?
So in this particular child, taking into account the history, I go with measles.
Okay.
It can also be differential diagnosis, can be other viral examples as well, like rubella, varicella as well.
Okay. So measles may come early in. Yeah. So measles is your first differential diagnosis. So what are the points favoring an infection like this, especially when you're talking about measles?
So in this particular child, his age is 10 months, and he had but classic features of fever, which was associated with cough, coryza, and conjunctival congestion, conjunctival involvement. And the way the mother described the rashes, it began exactly from behind the ears onto the face, and it spread towards the trunk and then the extremities. That also pointed towards a probable diagnosis of measles, and the history in immunization that he had skipped his vaccine at 9 months. That also made me think that it could be measles.
Sure. So one important history is the delay in giving the vaccination. Okay. Also, just remember that in the first 6 months, children. And first is that if it's a single child to a non-consanguineous parents, not from a very crowded place, children are usually protected from these viral infections by the maternally transmitted antibodies. And from 6 months onwards, the antibodies slowly start waning off. And once the child acquires a good hand-to-mouth coordination, more exploratory nature, becomes slightly mobile, and also starts having eruption of teeth, then he starts having an onset of these febrile illnesses. Some of it can be from transmitted from the immediate people in his family, and otherwise also from the community. These fever, upper respiratory tract infection. This is the age where it will start. Okay, so generally, a simple, if it was not associated with these rashes, we would still have attributed it to a simple viral upper respiratory tract infection. But now, because of fever, and we call it 3Cs, that is cold, coryza, and conjunctivitis, along with these rashes, which started in a very classical pattern according to your history, measles becomes our first differential diagnosis. Okay. And the other differential diagnosis are any other viral exanthems. Definitely, we will not maybe include varicella yet because the pattern of rashes are slightly different. From the history, we are not yet gone to the examination. Roseola is definitely rubella is one of the differential diagnosis, and other viral exanthems, which includes maybe enterovirus, adenovirus. These are the other viral exanthems which are there. So what is the atypical history in this? If you look at it, 4 days of fever, which was resolving with antipyretics, but again recurring. Then fourth day, a child was given antibiotics, and then one day following the start of antibiotics, there was an associated rash. Can it point towards some other etiology if we are separating the fever and the febrile illness and the rash as different etiologies? What else can be the differential?
Sir, drug rashes can be seen when a child is treated with antibiotics, other
Yeah.
drugs.
Yeah. So drug-induced rash is definitely one of the differential diagnoses. If you are separating the two symptomatologies as such. So if it's a febrile upper respiratory tract infection, received antibiotics and developed a drug-induced rash. What is against the drug-induced rash in this child?
So drug rashes, usually they won't have a fever or a prodrome, viral prodrome.
No, that is fine. So because of the fever, only the antibiotics were prescribed. Okay.
Okay.
On that, top of that illness, the child, if we had to say it has developed drug-induced rashes, what will be the pattern of rashes, onset of rashes, and type of rashes?
The pattern of rashes would mostly be starting from the trunk and then towards the extremities.
Yes. So it will not start in the back of the ear as we discussed, and then it not spread across the body, and it will start mainly from the trunk and then spread more, centripetally towards the peripheries. And what else can be the classical picture of that?
Sir, had it been an older child, it would be associated with pruritus.
Yeah. Correct. So older child pruritus in the sense, younger child also will have pruritus. Only thing he will not call it pruritus. It will just
Yes.
manifest as irritability, inability to sleep. Okay. Yeah. So and if the drug rash is much more severe in terms of developing Steven-Johnson-like syndrome, then it is also associated with serious mucocutaneous involvement as well.
Yes.
Okay. So with that kind of a summarization of a 10-month-old child incompletely immunized, presenting with a febrile illness followed by onset of rash, which started at the back of the head and spread. Our first differential diagnosis is measles, second viral exanthem, less likely possibility of a febrile illness and an antibiotic-induced rash. Anything else would you like to think about for a theoretical discussion? Any other etiology would you like to think about?
Sir, or based on the history, it could be Kawasaki disease.
Yes. So in infancy, when children come with high grade fever and then maybe a coryza, cough, reduced oral intake, little toxic looking, and development of rashes, Kawasaki, especially incomplete Kawasaki, cannot be ruled out because the classical presentation. What is missing from this history to call it a classical Kawasaki? In history-wise, if you have to tell.
History-wise, the child definitely had fever more than 5 days, sir.
Yeah.
And Kawasaki disease, it's usually infancy, it is rarer when compared to the age group of 1 to 5.
Okay, no, we are not. So it is not rarer, but if suppose an infantile Kawasaki was to present like this, the suspicion for Kawasaki has to be there. There is no
Yes.
doubt in that. Okay, because again the symptoms will manifest maybe after day 5 to 10 or day 5 to 15. Okay, and
Yes.
then but it is important for us to have high index of suspicion. Things
Yes.
which are missing is bilateral non-purulent conjunctivitis, which
Conjunctivitis.
the mother will tell as a severe redness of eyes, redness of lips, and the irritability will be very much disproportionate to the degree of fever. Okay, so child will be extremely cranky and irritable and very, very high grade fever. The other classical symptoms which we will have to find out on examination will definitely we will have to look forward to that. Means basically history means look for lymphadenopathy, look for strawberry tongue, very red lips. Okay.
Yes.
Subtle periangular edemas will be there, both on the dorsum of the hand and dorsum of the feet. And the late manifestations are anyway desquamation, which will come not on day 5, 6. But Kawasaki has to be having should be there in your differential as a high index of suspicion because it is treatable, and left untreated, it has got catastrophic consequences. Okay. So our 4 main differential diagnosis is measles as primary. Second is any other viral exanthem. Third is viral infection, queribacteremia with an antibiotic-associated rash. And fourth is Kawasaki disease. Okay. With these differential diagnoses in mind, let's proceed to the examination. Madam, do you want to add anything, madam?
No, sir, I think this was very thorough discussion. Thank you. I will ask towards the later part. Yeah, thanks.
Sure, madam.
Sure. So coming to the general physical examination of the child, the baby was alert, irritable to examination, and febrile. Hydration status was fair. Vitals, temperature measured in the axilla was 101.1 degree Fahrenheit. Pulse rate was 130 per minute, regular in rhythm, normal in volume and character, no radioradial or radiofemoral delay. Respiratory rate was 32 per minute and regular. Saturation in room air was 98%. Head-to-toe examination. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. The head was normal in size. Hair appears normal in color and texture. The anterior continent was open. Face no dysmorphic facies. Bilateral conjunctival congestion was present. External nose appeared normal. Watery nasal discharge was noted. Ears showed no discharge. Oral cavity, so it could not be examined completely because the child was completely refusing to open the mouth examination. On the neck, there were large lymph nodes. Chest appeared normal. Spine had no abnormalities. Genitalia were normal. Limbs appeared normal. Joints, there were no swellings or tenderness. Skin, there was this maculopapular rash, which was noted, that was pink reddish in color. We could find confluent as well as discrete rashes over the face, neck, abdomen, upper limbs, and lower limbs, but it did not involve the palms and soles. And these were the photos provided by the mother, which were taken at home in the initial days of fever. Means on the day when the rash started, and over the face. And these were the photos we had clicked on the day of examination. Anthropometry. The weight of the child was 7.48 kgs, lying between 3rd to 15th centile. Length was 74 centimeters, lying between 50th to 85th centile, and head circumference was 7 centimeters, which was on the 50th centile. Systemic examination. Respiratory. Coming to the inspection. The chest shape appeared normal. It was bilaterally symmetrical. The trachea was simple. There was no use of accessory muscles of respiration. There were no scars or sinuses noted. And on palpation, the inspection findings were confirmed. The trachea was central. The chest expansion was bilaterally symmetrical. Vocal fremitus could not be assessed. And on auscultation, the air entry was bilaterally equal and normal MBPS. Per abdominal examination done in the supine position. On inspection, the abdomen appeared normal. Corresponding quadrants moved equally with respiration. The umbilicus was central and inverted. We could note the rashes, which were maculopapular. There were no scars or sinuses. There was no visible peristalsis or pulsations. Hernial orifices were intact and external genitalia were normal. On palpation, the abdomen was soft with no local rise of temperature, no tenderness, no organomegaly. And on auscultation, the bowel sounds were present. CVS, S1 and S2 were normal, regular rhythm, no murmurs. Central nervous system examination, there were no focal neurological deficits. So shall I go into summary?
Yeah, sure. Then we can open the session for discussion. Yeah.
Okay. So here is a 10-month-old baby boy, fully born child to non-consanguineous parents as a late preterm, immunized up to 14 weeks, with appropriate development for age, no significant past history, presented with a history of fever of 6 days duration, followed by cough and cold, stools, reduced oral intake, and the appearance of generalized reddish rashes. On examination, the baby was found to be alert, febrile, but irritable to examination. He was found to have bilateral conjunctival congestion and generalized erythematous maculopapular rashes, which were confirmant as well as discrete on the head to toe examination. Systemic examination was within normal limits. The above history and examination is suggestive of fever with rash, likely of infectious etiology, probably viral. My differential diagnosis would be measles, rubella, rickettsial fever, scarlet fever, dengue fever, infectious mononucleosis.
Okay, so let's kind of delve into the general physical examination per se, or head to toe examination, what you did. It is okay. I think don't move the slides. It is all right. So you can open the general physical examination otherwise. So you spoke about conjunctival congestion. All right.
Yes.
So what are things which you look at in a child with red eyes in this scenario, especially a febrile child with generalized maculopapular rashes, still little toxic looking and having loose stools, poor appetite and poor feeding. When you examine the eye, what all things will you look for?
So in the eyes we would look whether there is a suffusion congestion. Where is the congestion present? In which part of the conjunctiva? Is it bulbar conjunctiva? Is it palpebral? Is it forniceal? And is there any exudate? Is there any mucopurulent discharge present or not?
Yeah, so one is purulent, non-purulent conjunctivitis. Okay. And second, as you told, the involvement of which part of the conjunctiva, what is its significance?
So, as in the case of measles, it would mostly be palpebral conjunctiva, which is suffused. Whereas had it been Kawasaki, it is most commonly noted in the bulbar conjunctiva, the perilimbal sparing. And in the case of vitamin A deficiencies, there is hyperpigmentation of the corneal conjunctiva.
Sure. So this differentiation is important. Palpebral conjunctiva, yes, measles, but difficult to examine in a child who's not even allowing you to, make your mouth open. It is difficult to examine. But yes, in Kawasaki, it is more bulbar conjunctiva. Mainly perilimbal congestion will be more common in Kawasaki. And as I told, the nature of discharge will be non-purulent in Kawasaki disease. And so, if suppose the child had purulent conjunctivitis, for all you know, what changes then?
So it could be of bacterial,
Yeah,
any
it can be a simple
infections, yeah.
secondary bacterial infection is possible, especially with your differential diagnosis. There are some bacterial etiology also you have described, isn't it? So, so, so bacterial component or bacterial secondary infection is likely when you have a purulent conjunctival discharge. Okay, coming to the oral cavity. Now, in these children, especially when they're crying, it is difficult to examine. But suppose you had a cooperative child or a child whom you could examine well, what are the parts of the oral cavity which you will look for, and what all will you look for?
Just that. Externally, we would look at how the lips are,
Okay.
whether there is any fissures or cracking, and the red, how much red is the lips. Then
Mhm.
whether about the tongue, whether it is erythematous, like a strawberry tongue, and the
Okay.
oropharyngeal mucosa is very much erythematous.
Okay.
And in the case of measles, we could look for oral enanthem, like a complex spot.
Correct.
And in the
Okay,
case of other, also we
yeah.
could look for a petechiae over the hard palate, the soft palate, the uvula.
Okay. And what about the throat?
Throat also, sir, whether it is congested, whether there's tonsillar hypertrophy, how about the posterior nasal wall? Are there any exudates?
Yes. So mostly you will have to look for, as you said, the lip and the nature of the lips, and whether any associated angular stomatitis suggestive of some background malnutrition also, because the weight is on a lesser side, which may be an illness-induced acute malnutrition rather than a chronic malnourished state. Inside the oral cavity, redness, the pattern of the tongue, whether it is a strawberry tongue, which means it is initially strawberry tongue is classical of which disease?
Kawasaki disease, scarlet fever.
Yeah. So scarlet fever, usually initially the tongue will be coated in white, then it will have a very strawberry-like tongue. That means on a red background, you will have whitish kind of dots. Okay. Ananthem cochlear spots, though it is described in textbooks, but very difficult to trace it. Where do you
Yes.
look for cochlear spots?
Sir, on the buccal mucosa opposite the lower second molar tooth.
Yeah, opposite the molar tooth in the buccal mucosa. So that's correct. And also in pharynx and pharyngeal examination, tonsils. This is not the exact age where it will have hypertrophy and exudative tonsillitis, but yes, pharyngeal congestion also is something you will have to look for. Okay. Okay, then if your primary diagnosis is measles, with that already you are on history and general physical examination, you have made that provisional diagnosis to be number one as measles. Rashes, what else will you check for in other than description of the pattern of onset, progression? What else will you look for when you're describing rashes in a sick, febrile child?
Mhm. So the type of rash, whether it is macular, papular,
Sure. Okay. What
and whether
else?
there are any vesicles, whether there's any blistering, any discharge,
Okay.
crusting.
Okay. So that what else can you look for? What is a rash exactly? It is just a temporary eruption which happens with
Whether
an
it,
illness.
sorry,
Okay.
sir,
Yeah.
whether it is blanching or non-blanching.
So what is the significance of that?
Sir, if it is blanching, it means that there is some underlying hemorrhage.
Okay. And or
Um,
how will you check for blanching?
so we have to press onto the either with a glass slide, we can press onto the rash and for 3 to 5 seconds and see whether the color returns back,
Sure.
whether the rash disappears or is it's still visible as such on applying
Correct.
firm pressure.
Yeah. So in blanching rashes, usually it's a temporary eruption which comes out with the illness of a viral exanthematous nature. It can be macular, papular, vesicular. So that is one thing. And then the onset of the rash along and its relationship with the fever. That is another thing that you will look for. The progression of the rashes. This is the third thing you look for. Blanching or non-blanching, you will also look for. Blanching rashes indicate more towards a viral exanthematous fever or a drug rash, or especially if it is associated also with pruritus. Non-blanching rashes always suggest some form of skin bleed. Okay, it can be purpuric rash because of a thrombocytopenia and a capillary rupture, which causes exudation of the RBCs into the subcutaneous tissue, and on pressure it doesn't blanch. What does blanching cause? Blanching moves the blood from the capillary network away. So in blanchable rashes, that is mostly viral exanthematous rashes, which are temporary inflammatory rashes or eruptions which come onto the skin, the capillary network is intact and it is more erythematous, but on putting a glass slide, it completely dissipates. Whereas when there is a skin bleed or vasculitis, there is a small microcapillary thrombosis or escape of the RBCs into the skin, those rashes don't blanch. And associated with that, if the fever is very high, if the child is looking very toxic, then how will it change your differential diagnosis? Now, we are just asking a hypothetical question, not this child per se, but a febrile child with a non-blanching rashes in this age group. What will be your single most important differential diagnosis, which you will have to address immediately?
So meningococcemia.
Yes, meningococcemia, because that is highly fatal. And then within next 12 to 24 hours, the child will need very active resuscitation, monitoring, and antibiotic administration. Okay. How is it different from the other tropical infection like dengue? Dengue also, because of thrombocytopenia, may have petechiae purpura. Okay. So how does it differ?
So the rate of progression, mental toxemia rapidly progresses into a more, whereas dengue has these phases,
Yeah.
a febrile
Okay,
phase,
so
then a critical phase.
So the non-blanching rashes or a thrombocytopenic rash in dengue will come in an afebrile phase. Dengue in the febrile phase, platelet counts are generally maintained. Only when the fever effervescence happens on day 4, 5, and then the afebrile period starts, that is the phase of capillary leak and also associated with thrombocytopenia. Okay. Then there is another pattern of rash in dengue, which happens during the phase of recovery. Okay. When the phase of recovery on day 7, 8, by this
Yes.
time, the child's general condition is improved. Child's appetite is better. He is looking more bright. But then there is a generalized erythema, especially in the peripheries, which are highly pruritic in nature. Okay, that's mainly because of an enhanced histamine release during that recovery phase, but it is in a slightly well child. Okay.
Yes.
So fever with non-blanching rashes in a sick child, suspect meningococcemia, and then have a very high index of suspicion for hospitalization, ICU transfer, and active resuscitation. A child who's been febrile then becomes afebrile with onset of non-blanching rashes. Tropical infections like dengue become important, and their hemodynamic monitoring becomes very important. A child who is otherwise dengue positive, but then appears a little bit well on day 7, 8 of illness, develops intense erythema and pruritic rash. Mostly it is a recovery rash. Okay, fine. So so now coming back to your systemic examination, if measles is your first differential diagnosis, what specific systemic examination will you focus on? What are you looking at exactly? So other way to rephrase the question is, what are the two most important complications of measles illness in a child who is 10-month old?
Child can develop pneumonia, sir.
Correct. So if it is day 5, 6, okay. But then if it was days 8, 10, the rashes have appeared, child continued to be sick and toxic looking, then the onset of secondary complications come in. Most important complication is secondary bacterial pneumonia. Okay, both streptococcal and staphylococcal pneumonia and its complications in terms of necrotizing pneumonia, empyema are known to happen in the post-measles state because there is also a depression of your cell-mediated immunity in these children. Okay, if you take history of measles in a child who is coming from a low socioeconomic status, staying in a very crowded place, these children also become transiently very, very high risk for developing tuberculosis. Okay, so if this child had a history of measles, say 2 months back, but now is coming with persistent cough, constitutional symptoms of fever, weight loss, lymphadenopathy, then tuberculosis also becomes one of the complications of the measles illness. What other acute complications are we worried about?
So the child can develop autoimmune keratitis.
And develop,
Keratitis.
so why does that happen? That is a very rare complication, but why do you think that happens?
So from the respiratory tract, it can affect the ears.
Okay, so
And
one
the
is
child
so multiple sites of purulent infections. That is one. That is maybe an otitis media, maybe a pneumonia. Okay, so this is the post measles bacterial infections. Okay, then we discussed about a slightly later complications because of transient dip in immunity. That is tuberculosis. What other acute complications are you worried about?
sir, acute disseminated encephalitis can happen.
Correct. So encephalitis. So measles encephalitis is important. So with that in mind, what you are described in terms of your CNS examination, saying no focal neurological deficit, we're not really looking at focal neurological deficit. We are looking at the sensorium and also the tone power reflexes of the child. Okay, not focal neurological deficit as such. So you will have to describe that. Two acute complications post measles is one, pneumonia and its complications. Second is encephalitis. Okay, fine. The other rarer complications, which is post measles illnesses, will be what else?
So at a later stage, the child can develop subacute sclerosing panencephalitis.
Yeah. So it is basically a post-infectious immune-mediated panencephalitis, which can happen. Okay. So that these are the complications of post-measles that you should remember. But acute stages, when you are doing examination for such a case in exam, respiratory examination has to be complete, looking for complications, especially pneumonia. Ear examination you have to do to look for any otitis media. CNS examination should not focus only on no presence of focal neurological deficit, but generalized sensorium and tone power reflexes also should be looked at. All right. Fine.
Yes.
So then open your slide on differential diagnosis. Okay. So in this, the second differential diagnosis is rickettsial fever, what you have told. So what is against rickettsial fever here, or for rickettsial fever?
Sir, again, rickettsial fever, in the history, the child did not have any history of travel or exposure to large domestic animals or the presence of any animal sheds nearby, or going to a forest area where there is a grassy, shrubby terrain. And
Okay.
in the case of
So rickettsial.
examination,
Yeah,
sorry.
please continue. Continue.
And also when it came to the rash, here it was rickettsial rashes mostly start from the trunk and then go towards the extremities, especially in the case of scrub.
What else? Another
And
important thing which you mentioned.
eschar was not found on physical examination.
Eschar may not be found. Basically, it is an extremity gangrene, especially in the earlobes or in the digital gangrene, because of a microvasculitis, which happens as in rickettsial fever. So, rickettsial fever, other important finding is involvement of palms and soles. Okay, the rashes will involve the palms and soles. So, rickettsial fever, there was no history of travel, no history of exposure to a situation where the child can be bitten by a tick. Okay, that means marshy areas, playing in the mud. Okay, having domesticated cows, buffaloes, which can contribute to that. Mostly a rural setting. Okay, especially in monsoon, post-monsoon phase. All right. So rickettsia is a tropical infection which is common in rural Bangalore, and many times we may not be able to differentiate it from dengue. It presents to us like a dengue-like fever, but then the platelets keep continuing. The pattern of rashes involves the hands and feet. Then we suspect rickettsia very, very commonly. What complications you described about in terms of eschar is not seen much. It also has an acute complications of
Gangrene.
Gangrene is one, but more commonly is meningoencephalitis also. Rickettsial encephalitis is also common. So rickettsia we have ruled out based on no history of travel, no situational history of exposure to mud or animals or a rural setting, which can precipitate tick bites. The pattern of rashes is very classical of measles. There is no involvement of palms and soles. Rickettsial rashes usually involves palms and soles. All right.
Yes, sir.
Right. So is rubella likely? What is for rubella? What is against rubella?
So the point that was against rubella is actually the rash would appear sooner than it wouldn't wait for 4 to 6 days after the onset of fever.
Okay.
And the entire prodrome would come down in around 3 days. And the rash itself would subside in around 24 hours, 24 to 48 hours. And on examination, the child would most probably could find lymphadenopathies, which was absent in this child.
Sure. So rash fades faster. Fever is slightly milder. Child is not so sick looking, and in this lymphadenopathy you could not find. What are the common lymph nodes we look for?
So post-auricular posterior
Yes.
cervical, suboccipital.
Yes. So it's basically post-auricular is what you're expected to answer in the exam. So rubella is a more milder form of illness, though the age group and because the child was not given the MMR vaccine at 9 months, it is possibility, but lower down in the list. What about scarlet fever? What is scarlet fever, and how common is it in this age group?
Scarlet fever is bacterial by a Streptococcus pyogenes.
Mm-hmm.
In the case of scarlet fever, when it comes to rash, it usually spares the face. It starts as a fine papular rash, which is like sandpaper on the neck. Then it goes to the trunk and extremities. And there
Yes.
will be other.
So because of one is that it is likely, one because the mother has had 6 to 8 days of febrile illness with her upper respiratory tract infection. So the risk of exposure is there because it is a highly contagious group A streptococcal infection. So
Yes.
child at 9 to 10 months of age, where its immunity is on the wane, can acquire a scarlet fever-like infection as its primary upper respiratory tract infection. But because the pharynx and was not so congested in this child, and also the pattern of rash was not classical widespread rash with a sandpapery presentation, the scarlet fever is slightly lower down in the list. Dengue fever we have discussed. What
Yes.
about infectious mononucleosis?
So in the case of infectious mononucleosis also, it's mostly in an older age group and associated clinical findings, what we see see on examination. There is no tender abdomen, lymphadenopathies, hepatosplenomegaly,
Sure.
etc.
So the reason why I'm asking about infectious mononucleosis is that, see, once you put it in the differential diagnosis, but then once you're asked to justify, you say it happens in older children with lymphadenopathy, with hepatosplenomegaly. Okay, so then you are kind of inviting trouble in the exam. Okay, so many times reflexly we want to increase the list of differential diagnosis, but then it is not relevant to that particular case.
Okay.
All right. So that's why don't put a differential diagnosis for which you have no defense in terms of both the history and the examination. Okay.
Oh.
So better to leave it as any other viral exanthematous fever. I would rather put that after measles rather
Yes.
than having infectious mononucleosis in this list.
Yes.
All right. Fine.
Sure.
So with the history, physical examinations, negative history, negative examinations, now how will you go about proving your diagnosis or ruling out other differential diagnosis? Do you want to do any diagnostic test, or it is only a clinical diagnosis
We could test for measles IgM antibody.
Okay. So
Apart
when you are
from
asked
the test that we do, we
yeah,
would add. And in this particular child, it had come out to be positive.
okay. So are there any more slides, or this is it?
Oh, so this.
Yeah, okay, fine. Okay. So when you are asked this a question in the exam, you will have to start with, I will start with baseline investigations. Okay. So what are those baseline investigations you will do for this child? Again, in this, when you talk about in the exam, you will have to mention in this child, what are those baseline investigations which you will do?
Sir, child, I would go with a complete blood count. And inflammatory marker, I would choose CRP.
Okay.
I would also, because the child has cough and coryza, I would go for testing with some viral panels like R1 panel. And then GRBS and
Okay.
electrolytes,
What else?
the creatinine, liver function tests.
Yes. So CBC, CRP, renal function test, liver function test becomes important. Okay.
Yes.
I would still not put a nasal swab or in this child for a viral to look for any other viruses, because those are not detecting the differential diagnosis which we have discussed now.
Oh.
Okay. So
Okay.
in case it comes out with, say, HHV6 or influenza virus, influenza A, So that is a rarer possibility. And these viral panels of nasopharyngeal swab is not available everywhere. So among the differential diagnosis that you have put across, your investigations has to correspond to that. So accordingly, instead of saying nasopharyngeal swab, you can say throat swab to look for group A beta hemolytic streptococcus. Okay. So that will be a more better answer for this case in the exam. All right. Then you will also look for specific investigations to rule out the differential diagnosis that you have mentioned. In that, you will put about measles IgM.
Yes.
Okay. Anything else along with that?
So with respect to the differential diagnosis that I've
Yes.
taken,
Yes. Yeah.
so for rickettsial infections, we can go for a scrub typhus IgM. We can do the
Okay.
Felix test to look at the OX219K positivities. Then
Okay.
dengue fever, we can look at ELISA tests for dengue NS1 as well as IgM.
Sure. So that will form the next line of investigations to find out the exact diagnosis. Measles IgM, rickettsial IgM, throat swab for kind of group A hemolytic streptococci, dengue NS1, IgM and IgG through an ELISA method, or even a card method. If you tell in the exam, that will suffice. So when you are asked about investigations, one is generic investigations to look at the general condition of the child and its complication, especially in a febrile child, poor oral intake with diarrhea. Electrolytes become very important. You should not miss the renal function tests and electrolytes. Okay. So, and then all these things. So, madam,
Yes, sir.
anything else, ma'am?
I just wanted to ask one thing about it's. I'm glad that a lot of points were discussed and it was quite a detailed discussion. Thank you, Dr. Chetan. Kripa, when you see this child, let's say this child comes to your community clinic. So how
Yes.
will you approach this child? Yes, you have examined, you have seen this child. So what are the factors will determine you to decide this child can be managed as an outpatient setting, or does this child needs to be sent to a hospital for further management? Because as a physician, that's an important thing you should be aware of. So what criteria you will look at and how will you counsel the mother about it?
Ma'am, mother brings her child with fever to the clinic. We would, after taking the history, doing the physical examination, checking all the vitals, see how the factors that would decide whether the child is okay to go home on OPD basis or whether the child should be admitted, would depend first on the vitals and the appearance of the child, whether he's very toxic, sick looking, too much irritable with an inconsolable cry, that would warrant admissions. And whether child is having fast breathing or a noisy breathing, the respiratory rate of the child, and also whether the child is dehydrated. Yes, is there persistent vomiting? Or even while in the clinic, the child is having continuous loose stools. How alert is the child? How is the sensorium of the child? All these dehydration status, all these factors.
Yes, I think the important thing where we have to remember is, I'm sure Dr. Chetan can also add few things in this. Few important things which I generally recommend is one, the alertness of the child. Number two, the hydration status. Also, it's important to check about the urine output of the child, the intake of the child. All those are very important. Three, the duration of the illness. Four, how well the mother is comfortable handling the child at home. So all these factors play a role. Dr. Chetan, is there anything you would like to add?
Only thing will be see the evolution of the disease. If the child is becoming progressively sicker over time, because new symptoms are getting added on only. Fever started, then cough coryza started, then loose stool started, then rash came. Child has not had any decrease in the symptomatology. Child has started to have poor feeding, So definitely the evolution of the disease suggests that child is progressing in terms of the illness. And with the almost 6 days of history, we would rather err on advising, taking the family's understanding of the situation and their ability to manage the situation towards more towards hospitalization, like you did in this child. So, and then even though it was at the maybe fag end and with the supportive treatment itself, child recovered within a day or two, but that decision at that point of time can sometimes be life saving, because if the child is slipping into secondary complications of pneumonia, which comes to you 48 hours later, or say meningoencephalitis, which comes to you 48 hours later, then it's a at that time to bring the child out of that complications of their acute illness is significantly more time consuming, and more interventions will be required. So like Madam told, I think in a OPD setting, in a community setting, first progression of the disease in the child, whether the child is in the recovery phase or in the continuation phase of the illness, and also assessing all the other parameters in terms of oral intake, fluid intake, urine output, and understanding of the family about the illness becomes very important. So in children, and especially infants, it is better to err on the side of monitoring in a hospital setting rather than sending them home.
Do other participants have any questions before we complete the presentation today?
So what exactly did you treat this child with? Now, in one day, child made a miraculous recovery. You proved measles IgM positive.
And also, I examined the child on day 2 of admission. And initially, the child, because it had an elevated CRP, where though the total counts were in normal limits, in addition to maintenance, supportive management with maintenance IV fluids and zinc at supplementation for in with respect to the loose dose, the child was started on IV augmentin for 2 days. And
Anything
then
else you could have done? Yeah.
so on discharge, the child was given vitamin A supplementation.
How much vitamin A?
Because the child was 10 months old, so it was 1 lakh international units on to be given on 2 consecutive days.
So total dose of 2 lakh international units. Okay, yeah. Because of the extensive mucocutaneous involvement. So how does this vitamin A help?
So it helps in epithelial repair.
Correct. So it helps in epithelial repair. What epithelia are we trying to repair in this child with
Intestinal
measles?
epithelium.
What else?
Respiratory.
Periorificial mucosa.
No. More common. Respiratory epithelium. Somebody mentioned that. I think Fatima mentioned. So because the cause for secondary pneumonias is basically epithelial denudation in the airways and the alveoli, and secondary infection to that, and then conjunctival epithelium. Okay, so conjunctiva, respiratory, and intestinal epithelium is what you're trying to protect from
No.
the post-measles complication. All right, fine. So you gave supportive treatment, fluids, a broad spectrum antibiotics covering strep and staph, and fever control, and you gave vitamin A on discharge. Okay, good. Anything else, ma'am? Closing comments from your side?
Does anyone have any queries?
There is a question there, Nishant.
Yeah, Dr. Kirti has asked a query. All parents complain that children have poor oral intake during febrile illness. How do we assess the need for hospitalization for poor oral intake? Is it safe to send child home if oral intake and hydration is normal?
Sir, it was echoing. Can I read the question anywhere?
So it's in the chat box. So basically, on an OPD setting, how will you assess based on oral intake and hydration whether the child can be sent home safely or you need to hospitalize the child? That is the question.
The poor oral intake would depend on how frequently the child is being fed, like whether, in the case of an infant, every 2 hours, every 4 hours, for example, some 100 to 150 ml of feed, and how well is the child latching onto the mother in the case of a breastfed infant.
Okay. What else?
And of course, checking the hydration status of the child, whether the child is dehydrated or not, and how much is the urine output as reported by the mother, and is the child always showing this refusal to feed or cooperative with feeds?
Sure. So the thing how we answer this question is, see, when on an assessment in an OPD basis, when every mother will say my child has stopped eating with any acute febrile illness and an upper respiratory tract infection with a nose block, children's oral intake will definitely drop. Okay,
Yes.
to almost 50% to 20, sometimes 25% of its natural intake. All right. So in this case, especially in an acute febrile illness, what is our aim of oral intake? More than giving solid food, it is main to maintain. It is ma- it is mainly to maintain hydration. All
Hydration.
right. Yeah. So hydration is very important. With that, if the urine output is maintained every 6 to 8 hours, then we would say that if the child is thirsty, if it is drinking at least water, then the hydration part is taken care of. Oral intake, we assume it that it is going to be less. So how do we advise mothers? Instead of giving 3 or 4 big meals, we always
Yes.
advise that small frequent meals is the way forward when children are acutely sick. 3 to 4 spoons of semi-solid feeding every 2 to 3 hours if the child takes, and then it is all right. If this much if the child is doing and is able to pass urine 6 to 8 hourly, we will accept it, and we can take the risk of sending the child back home. But if the child is not able to take water, not able to take solids well, and also is refusing medications, and that's why the likelihood of complications in an evolving illness is high, then it is better to shift the child to an hospital setting for close monitoring and observation. So there's another question: how is this child's protein intake more? How do we assess breastfeeding with frequency and volume apart from urine output and hydration status?
Sir, when I took the diet history, it came out to be a little excess of protein. And
So, what were the source of protein in this child's 24-hour recall method that you calculated for?
sir, the child had more ragi, and dals were included more. And then child had cooked rice as well, and formula feeding is also continued on and off. Dals
So,
and pulses and sambar were
yeah,
often given.
but yeah, so there is a discrepancy in what you're saying, because all the sources that you described, whether it is ragi, whether it is dal, whether it is milk and milk-based diet, all combinations of carbohydrate and protein. Okay, and it cannot happen that the protein component or percentage is slightly more and carbohydrate is less. Okay, so we will have to recheck, and whenever in the exam you find a discrepancy like this in a pure vegetarian kind of and milk based diet, the likelihood of protein excess and energy deficit is very remote. That may indicate that there is some false assumptions or false calculations. So just be mindful of that. Okay.
Okay.
So the other question is, how do we assess breastfeeding adequacy other than with frequency and volume apart from urine output and hydration status?
So breastfeeding every 2 to 3 hours for an infant, or 2 to 4 hours for an infant, and if the child is breastfed at least 3 to 4 times a day in total, that itself would contribute to around 250 to 300 kilocalories per day. It was a child who has already been weaned off.
Yeah. So again, there are two. If you ask this question in the exam, you have to answer in first 6 months of life in an exclusively breastfeeding child. If the frequency of breastfeeding is say 6 to 8 feeds per day, when the child passing urine every 6 to 8 hours, sleeps comfortably after feeding, and is not looking dehydrated, irritable, then the child's adequacy of breastfeeding is intact. And it is also documented in the medium term by a regular weight gain of say 15 to 20 grams per day. By that calculation, in a month, child should gain 500 to 600 grams. So whenever the child comes to you at 6 weeks, 10 weeks, 14 weeks for vaccination, the other thing you should look for is the weight gain. Okay. The other indirect ways of measuring breastfeeding adequacy is whether the fullness of the breast in mother is reduced after a good feed. All right. So that these are the ways to assess the adequacy of breastfeeding in an exclusively breastfed child in the first 6 months. After 6 months, once the complementary feeding is started and achieved, breast feeds per se are kind of top up and mainly for comfort feeding. So a child may feed, like you said, 4 to 5 times in a day. And if mother is comfortable without any breast engorgement, the breast empties well, and child is gaining weight, and also the complementary feeding is progressing in a way where more and more variety of food is being added on as time progresses, then we are happy with a combination of complementary solid feeding and breastfeeding. Okay, so that should be your answer in the exam. Two components: one is exclusively breastfed child, one is a breastfed child with a complementary fed child. Anything else to discuss, ma'am?
No, sir. I think we have discussed quite a few important things and very useful. Thank you so much, Dr. Chetan. Thank you, Kripa.
Thank you.
Thank you very much, Chetan sir,
Thank you. Thank you, sir.
for a very nice discussion regarding the case. I'm sure the residents found it very helpful. Thank you very much, sir. Thank you very much, Srividya ma'am, for a very practical approach of child with fever. Thank you very much, Dr. Krupa, for a very good case presentation. So, Spice Route Karnataka is planning to have case presentations every third Wednesday of every month. So, residents who are interested to present cases kindly contact Dr. Lijo, or 360-degree PG coordinator. Thank you, everyone, for attending this class.
Thank you, sir. Thank you.
Thank you. Thank you, everyone.
Thank you. Bye.
Bye.